So we have Brandy Deffenbacher, one of our family medicine faculty and longtime preceptors, also the longstanding clerkship director for community and primary care. We have Vishnu Kulasekaran, who is the director of the Denver Health Longitudinal Integrated Clerkship and has also been precepting in that space for a very long time. And Elena Laduska, also a internal medicine clerkship preceptor for ages and our clinical content director in our TREC curriculum. So welcome and thank you so much. I'm going to suggest you use, it's flashing. Nope, there you go. This, does that work?
I think, does this work? People hear me? Perfect. All right, well, good morning, everybody. Thank you for coming, both for those of you on Zoom and for those of you here in the room. As Jen mentioned, I'm Brandy Deffenbacher. I am a longstanding preceptor as well as clerkship director, as well as content director. So I wear a lot of hats. But I think one of the things that has always sort of given me pause is how can I precept and stay on time? And so we hope to kind of have a little bit of a discussion this morning and hope that you leave with a few tips that you can implement in your own clinics. So first off, I want to hear what are some of the first things that come to mind when we say time efficient precepting? And if you're on Zoom, put it in the chat or you can unmute yourself. So just shout it out. What do you think? What is the first thing that comes to mind? Impossible. Okay, what else?
Presenting.
Doing it real time.
A couple things I'll just read from the chat. Presenting at the bedside and staying on schedule in clinic.
What else? Be strategic. Okay. 1 minute preceptor. Excellent. So some good ideas. Narrow your focus. Any other maybe not so friendly thoughts around time efficient precepting? Like, yeah, that's not possible. Shame, stressful. What do I do when it's just a busy day and I have a student? Multitasking. Anything? Yeah, so I already know that I'm not efficient myself, so adding a student just is an extra thing I have to manage. Less time for patients. Anything else? Managing new staff as well as students. Excellent. Yes. Anything else? Exhausting. Yeah. Okay. So we heard some strategies, which is great. And we hope that you are all able to leave this talk with a few more. We heard some of the more negative
notes.
kind of, oh, here's some more.
Just one more, med student notes.
Med student notes. Positive, negative, leaning more towards positive now, which is great. So what we are going to share and hope that you're able to leave with is a way to organize the ambulatory setting to optimize the teaching environment for your LIC student. Be able to identify a toolbox for successful precepting during those busy sessions, and then create strategies to prepare students to be successful. Now, I do want to say that all three of us are ambulatory primary care providers, so we do kind of have a lens with that environment, and we recognize that that is not the environment for all of you that are here and all of you on Zoom. And so we would still love to hear from those of you in other environments, how you work on time efficient precepting with your students. And then turn it over to Elena or Vishnu.
Sure. Thanks, Brandy. So this is a great list. We added a couple more. Also, you're not getting paid for this extra money, so there is an extra cash, which I think is a cost, and time. I think you all alluded to this as well, that we don't have extra block time for seeing these, working with the students, or have less patients in a clinical session when we do have a student. So we also want to put that out and acknowledge that. Dr. Adams went through this in detail about the benefits of teaching, and I just wanted to highlight a few of these. But really, the ability to have a student to partner with over the entire year, and also have a student that can partner with your patients and spend that extra time giving them a call after you saw them and diagnosed depression and started a new medication, having that student call that patient a week later when you might not have the time to do that. The mentorship opportunities are great, and I'm in touch with all of my students, my past 9 students over the years, and that's probably been the greatest joy for me in terms of teaching in an LIC. It really keeps me on my toes too. I always have to be up to date on things and have my students teach me as well, I think is a huge benefit of the LIC. Good, next slide. So a big question is, what should you be doing when you are precepting? How many patients should the students see? How many notes should they write? So we surveyed our faculty back in 2019 to kind of get at that, to give us a rough guide of what are most people doing with their students in clinic. And what we found is on average, students are seeing about 1 to 2 patients early in the year, probably more like 2 in the beginning. Towards the end of the year, about 3 to 4 patients. And on average, writing about 1 to 2 notes per session. It is certainly a bell curve, and maybe your more advanced students are doing a bit more. But that's a pretty good standard, at least for starting out the year. We found lab follow-up is variable and difficult, but what we do find is students engage in that about a third or halfway through the year more, once they're more comfortable in their different specialties about how they can call patients and do lab follow-up. And that can really create that authentic role, independent practice that we really want our students to create or to develop over the course of the year. So before I pass it off to Elena about some tips about precepting, and then we're going to break into small groups here, as you can see with the papers on the wall. In general, I just like to say when I like to give my students a couple patients that I know that they might see during the session, but also recognize that we need to be flexible. So if I start the clinic out and there's 3 patients already arrived and we're already behind, that's when I'm going to split up. And I'm going to say, I'm going to see these 2 using this one. If there's only 1 patient there to start the day, then that's a great opportunity for me to directly observe my student and sit in the room and scribe and take notes and actually improve my efficiency by already writing the note and putting in orders. And then I've also done direct observation, and I can give my student feedback right off the bat. And I try to do 1 episode of direct obs per session at least.
All right, so I think it's really important to start off your precepting like being very prepared. Like the student's going to show up. We already got some feedback from Jen about what to do prior to the first day, where you have to go, what your expectations are. But there are certain things that I like to make sure that they understand on the first day. So one of them especially is, what is the clinic structure and workflow? So what I mean by that is, how many rooms do you have? How do the patients come in? My patients are scheduled to arrive 15 minutes before they see me. What does that mean? How much time does the MA spend with them? When does my MA need to go to lunch? And why is that important that we finish on time? Do I see patients in the afternoon? What do I do, while in between visits? Because it's not just seeing patients, right? So really trying to make sure they understand the clinic workflow. Secondly, what is my expectation for the student? I think we've said this a couple of times now, but students want to come in and see every patient. Right? They think that's what they're doing a good job, how many patients I can see. And I really try to tell them, I think Brandy has given this feedback before, like how many does the intern see on day 1 of clinic? They see 1 patient. So the student should see 1 patient. That's very good. Oh, this is good. I make my students responsible for the clock. So what that means is students will spend 2 hours with a patient, right? And on inpatient medicine, that's great. The patient is locked in there. They're going to be there for 48 hours. It's fine. Outpatient medicine, obviously, that is not how it works. So making sure that I set very good expectations of you're allowed to spend 15 minutes with the patient, and then I spend 15 minutes with the patient. And I think this is really important to understand what patients are taken care of. I take care of a specifically very well-educated, affluent patient population who is very nice and spends a lot of time with my patients, but then they also expect to spend that same amount of time with me. And they feel gypped if they spend 20 minutes with a patient and only 5 minutes with me. So I just set some expectations and I make sure the student understands what time I need to see each patient and when we have to sort of be done. Okay, create options for tagging out. So we're all going to have a horrible day for some reason. Your patient's super sick, they're suicidal, you're running late, you have personal issues. So it's totally fine for 1 or 2 days during the year for you to tag out. So what that means is you're not working with the student that day, and that's okay. I actually allow my student a day to tag out too if they're having any personal issues. All that means here is we're going to do something else with the student, okay? And we'll give you some examples of what else you can have the student do that's great for education, but doesn't involve your direct care. And the most important thing for this is just having a plan for that day, so you're not trying to scramble and figure that out at the last second. Adjusting to space limitations. Maybe you're in a clinic that only has 1 room. How do you sort of work around that? What can you do pre-visit, post-visit? Where can you place the student? Because that does become an issue, especially in our smaller clinics. And thinking about ways the student can actually make clinic easier. So there was a question in the chat about the notes. I have my student finish 2 of their notes, which is the only 2 I allow them to write while we're both in clinic together. Because then I am able to go through the note with the student, give them feedback on that note, and then I am done. The note is co-signed. There's 2 notes out of my 8 notes that I don't have to worry about later on. And I make sure any notes I'm not going to use for the student have been deleted out, so I don't have to worry about me trying to close the note later on. So in explaining clinic and workflow, how do we go into that a little bit more detail? We mentioned before, number of rooms, what else is happening, when should patients come in, what are the transitions? I think we're all inherently selfish. And what I mean is we only think about us. So especially for my MA who needs to go to lunch at noon so she can start rooming someone else's patients at 12:30, really explaining to the student that we can't just run out over an hour. Like my MAs have to get home, pick up their kids, all of that stuff. So letting them know that. And making sure that the student understands that the learning is not just involved in seeing the patient. So following up the test results, answering patient message or triage. What else do I normally do during my day that the student could also learn about as well too? And can they actually do some triage for my patients before they even come in? And lastly, because I'm an internist, really thinking about the contrast between in-patient immersions and outpatient medicine. No matter what subspecialty you're in, your surgery clinic outpatient is going to run very differently than surgery inpatient. So what are those differences and how do we sort of teach the student about that, especially in terms of time constraints and space? And lastly, if the student understands how the clinic works, which is why I think it's important to dedicate some time to this, they can really be more cognizant of natural limitations of the clinic structure and your natural workflow. And I think really puts a lot less stress on later on. Because I know one of the biggest stressors for me is getting behind and my patients being upset and the clinic being upset. So keeping on track, I think, is really important if you sort of start off. Okay, so what do I expect from the student? Again, student wants to take time with that patient, get that history, really being explicit about that, setting realistic expectations about how many patients they should see, allowing the students to agenda set, but giving them prioritization, like Jen mentioned. Patient was discharged from the ED with chest pain. That's probably going to be my most important thing I want to focus on. And then really making sure I respect my clinic team and making sure I introduce my student to all my clinic team on that first day so they can build that relationship and understand everyone's role. Lastly, when we mentioned space limitations, trying to find that extra space, some people actually have their patients come in early when they know they have their clinic. What can you do pre and post visits? So I'll have my student actually do a lot of follow-ups for my patients to go over their medications, or with caregivers that actually take care of the patient after the visit. Can the student bring a laptop in if there's space constraints as well? I really call this I type, you talk. So what that means is we both go in the room together. I type the entire note and finish it before we are done in the clinic room, while the student gets 100% 30 minutes of direct observation in their history, physical, and assessment and plan. I think this is very time efficient and really makes the student feel like you spent a lot of time with them without getting behind, because it's the same amount of 30 minutes. If there is a question about the assessment and plan, we'll tell the patient we'll step out for 5 minutes, debrief, and then come back in, and the student will give the assessment and plan for the patient visit. All right, so I think we're gonna break out into some small groups.
So we are gonna move around the room now, and we hope that you meet someone new. And for those on Zoom, we're gonna split you up into breakout rooms. So we'll just take a couple minutes to move. So our goal is to have you be with potentially people you don't know, and so you can meet some new people. And we're gonna be in groups of, for the in-person, in groups of 5. So you can see there's paper on the walls here, so you can stand up and move to one of the pieces of paper here and get in a group of 5. And then, yes, we will be, for those on Zoom, you'll be sent to a breakout room with either Dr. Adams, Dr. Deffenbacher, or Dr. Lubduska. Yeah, you can go quiet, whichever, and I'll text you. Yes, Angie will. All right, so I'm glad to see everyone's introducing themselves. Thanks for working with us in this room setup. What we're gonna do is we're gonna give you all 10 to 15 minutes in your small groups to sort of talk through some of the challenges in terms of what are the barriers for efficient clinic precepting, because there are many. And so we'd love for each of you to share with your group what you do or plan to do with your student when precepting. And if you're not in the clinic setting, I think this is also relevant for if you are in the emergency room or other settings, to share how you structure your time with your student. And then be able to give feedback and suggestions to your colleagues. So have everybody have the chance to share sort of your clinic setting and what maybe some of the challenges are, and see if you can get some feedback around ways to address those challenges. So I'll keep the time, but about 10 to 15 minutes. Thank you. Feel free to use the markers to write down ideas, because we're gonna report back out. All right. Our Zoom group is coming back together, so we're gonna try to, I love that there's still conversation going. We're gonna have groups share out to the larger group, sort of what you've been discussing. There's been great discussion, so I'd love to hear you all share. And I see our Zoom group back. So we passed around some mics. I hope they're working. If not, I'll run this over. But if any of our groups would like to start out, Shama, is that one working?
Sure. Hello? No? Yes? Is it working?
It's working.
Okay.
Okay, so our group came up with a couple of different things. For inpatient precepting, folks are assigning having their students pick 1 or 2 patients for the day at the beginning of the week, and towards the end of the week, having them pick up 3 to 4 patients by that time. And they also pick up new patients potentially through afternoon consults. Our group really liked the you talk, I type the idea in terms of efficiency, and especially with new visits. Also, if you have multiple learners, like a medical student and a resident, maybe sending the medical student in with the resident, and the resident types the note, and the medical student does the, history taking and presenting to you afterwards. Another important thing in terms of being efficient, we thought, was the huddle right at the beginning, trying to make sure everybody knows who they're going to go see, especially if you have multiple learners, so that the students are not floundering with a really, really difficult patient that may be beyond their skill. And number 4, focused goals we thought were important, coming to each clinic with a specific goal in mind. I want to work on this part of the physical exam. I want to work on this part of the assessment, something really focused so that they can get feedback on that. And for proceduralists, using an educational timeout in the operating room or before the procedure is helpful for focusing the students' goals for that particular case. And so that you can give them feedback directly on that specific goal, whether it's, I want to place the interrupted suture, I want to place the closing suture, whatever it is, but trying to be really granular about that.
Those are great. Thanks, Shama, for reporting out. I do think the point you all made about teaming up with residents is a great one. So a lot of our residents are so eager to teach students, and oftentimes don't get that opportunity in the outpatient setting. So letting them sort of take on that kind of attending role, being the scribe for the student can be really satisfying for our residents as well. Great, you can pass it on up.
Okay, I think we had a lot of similar ideas. Just for context, we're all sort of outpatient primary care in our group here. Reviewing the chart beforehand, both setting the expectation with the student to do that beforehand or the night before, and then as the provider, and then syncing up in the morning. And if you have a match of the patient student wants to see and you want to see, I think that's great. We also mentioned being flexible. Things don't always go as planned, and setting that expectation as well, so that the patient doesn't show up or they show up late. Maybe if that patient you wanted to see, they show up late, then you kind of move to sort of the scribe role, which was something else that we talked about and the other team talked about, where you're taking the notes and the patient's doing the interview to be more kind of time efficient. We also talked about using tech to help communicate and keep the student involved in the care, and that's with the MAs. We have some providers here who work with several different MAs, and so Epic Chat is sort of essential, but keeping the student engaged, or I guess we also use Vocera, and so the student can do that, have one of those as well. Also setting the expectations before the encounter. So whether that's, I would like you to focus on this particular aspect, or just the history, or we're just going to do the physical exam. Also, if you know particular things about the patients, if they are very chatty, letting them know beforehand some of the challenges you might encounter. Also, I guess along being flexible, but also giving more plenty of exposure to students. We talked about engaging the interdisciplinary teams. And so you have a patient who then, this is an example, I think the first presentation, they need to see social work, behavioral health. Having that student then follow those other team members throughout that session. Also just making sure the student is part of the team so they can easily kind of work with everybody, whether that's MAs or nurses. And then also we talked about if you're behind with patients, staggering, and so you go and see one patient or two patients, and they're going to see another. That's pretty much it.
Great, thank you so much. So I heard a couple great themes there that I'll just reiterate, but one was flexibility. So making sure that you have that potential schedule for your students to see, but acknowledging that if a patient no shows or something else happens, that they need to be flexible, I think is so important. I loved your point about the heads up on certain patients if they do tend to be talk a lot more, to help them focus more on agenda setting, because then if they don't have that heads up, that they could get stuck in the room for a really long time. And so helping them out there is great.
Hi, good morning. Good morning. So it's similar. We talked about pre-session huddles, planning which patients to assign to students, and then assigning them topics to read about and report back if there's some downtime in between, and using pockets of time for note review and feedback. Then also assigning students to accompany, like patient educators, social workers, like you guys were talking about. I'm an emergency physician, so I do a strategy which is I call it teaching to the room, because I assume everybody in the room is learning something, including myself. So I sort of go through what's going on with this patient. What do we have? What do we know? What do we need to know? And I tag team different people in the room depending on order of, like, what do you think's going on here? Okay, resident, jump in and help out. What else do you think's going on here? And sort of this staggered layer of teaching where it's not confrontational. It's very much collaborative. Like, who else has things to add to this picture here? What else can we do to improve this patient's care? Making expectations clear to the student and building on similar cases. One of the things I like to do is called what I call build the tree. So you build the trunk. The trunk is shock. Then the branches are what are the types of shock, and then the leaves are all the things you need to know about, let's say hemorrhagic shock. So, we just had a case of shock, for example, in the emergency department the other day when I had students and residents and everybody else, like EMS and everybody else in the room. So, what do we have? Okay, we have low blood pressure. All right, and the person's not really confusing. So what do we call that? Eventually somebody says shock. Okay, great. So what kinds of shock could we have? And then, the student will say something like, oh, I've heard of, like, you could be bleeding, could be hemorrhagic shock. Okay, great. Is there any other type of shock? And the resident will be like, yeah, there's a few more. The student will be like, well, maybe infection. Okay, good. So now we start to, and then maybe nurses jump in, right? And so it becomes this collaborative team effort. And invariably, you're going to see another shock case. I mean, maybe not in the clinic. I hope not in the clinic. But, in my day, I'm going to see at least another shock case that day. So now we start with, okay, we already know about hemorrhagic and septic shocks. What other types of shock are there? And now the students like really engaged because, wow, the tree is getting bigger and fatter with more branches and more leaves, right? So that's my favorite style of teaching. Did I cover everything we talked about?
All right, so I had one of the breakout groups, and I'm just going to contribute a couple things that these groups have not shared. Some of the I had a lot of outpatient providers, many who have 20-minute visits, and a couple things that they shared is, especially as a learner is new to the clinic and just getting used to everything, is they have them see new patients so that they can practice kind of that full history taking, and then in their instance, their clinic provides them a little bit more time for the new patients, and so they have a little bit more space for that. And then the preceptor will see the follow-up patients. And then as the learner has been working with you longer, they start to see some of those same patients that they maybe helped establish in the clinic. Others did the bedside teaching. So again, kind of the scribe, but also others, they would have the student present to them outside the room and then come back in and have the student provide the plan to the patient. And then as students are developmentally kind of ready, they start to have the student pen to orders. So depending on what your EMR is, the student can pen to orders for you so that, maybe by the end of the academic year, you can really be like, yep, all of these are correct, and you sign them as the preceptor. I think those are really some of the others that have not been mentioned, other than notes. So if you are running behind, it's okay to have your student sit outside and work on their notes and kind of finish those up as you get caught up with patients. And that is totally fine and a-okay, so that they have their notes done before they leave clinic for the day.
All right, so would anyone on Zoom like to? Sorry. There we go. Okay, good. Just having the students work as the MA if they're getting sort of behind, because there is value in medication reconciliation, rooming the patient, why they're there. We have another one in the chat here. I'd like to put in one more plug for having students do interviews while getting guidance by IM, text, whatever method, if that's doable. So getting some other electronic feedback and information there. And then one other thing that came up that maybe some people have some thoughts about too is if you're a very subspecialized preceptor, how do you sort of make sure that you're including the general topics that needed to be included? So that there was an example of a gynecologic oncologist and how to make sure that the student is still learning the other gynecologic things. If people have feedback or subspecialists in the room want to give their thoughts on that.
Yeah, so our group, I think, had a lot of overlap with what everyone else has said so far. I think one of the things that we talked about too is maybe more of a suggestion going forward of having like some sort of repository for each specialty that you can, maybe like a Google Drive or something that you can go to pull articles so that you can give them to the students, so that we as preceptors aren't spending our time each putting together our own repository, that maybe it could be something that could be shared or added to among all the different LIC sites. Anyone else?
We have all the same stuff as everyone else. We did talk about this thing called SNAPS. Basically, it's an acronym for having the student pick their own topic and then come back and talk about it. I guess the only thing no one has mentioned is we like to emphasize having fun, because that will make them relaxed and work to their best selves.
I think the one piece that we had that might be a little different, or just adding on what other folks have said, is when picking out patients, if you have the availability with clinic rooms and communication with the patients themselves, see if you can have them actually come in a little bit early to give the student extra time to work with them, and that way you're still staying on schedule.
Hi, all. My name's, well, that's loud. My name's Eric Young. I'm a hospitalist at the VA and run the VA LIC. We talked about a lot of the same stuff. The one just sort of story that I included from my perspective on the inpatient medicine service. For those of you all who remember like inpatient medicine rounds, you probably remember like standing around for hours and hours and hours talking. And I, about like a year ago, just kind of realized that we were spending so much time presenting full history and physicals at the bedside in a modality that really doesn't serve students in terms of like developing their ability to succinctly communicate clinical care. So shifted away from that model and have basically have students a new structure that focuses on the main historical features, exam findings, and then the assessment and plan being the bulk of it. And what just has impressed me upon that, and I think the lesson that I feel like is probably applicable across the board, is our students will aim at whatever structure we give them. But if we don't give them a structure or we use what has historically been done, like that will inevitably default to sort of lengthy presentation. So if they're presenting and it's taking too long, give them the structure to make it shorter, whether that's saying focus on the top 2 problems, or even here's your time limit and we're going to time. I think that can be done effectively. So that was just my one kind of experience and feedback. So.
All right, I had Zoom room number 3, and I'm just going to call out Mandy Swanson. She was in my group and puts an awesome suggestion that came from our group in the chat. Mandy, do you want to turn on your camera and summarize for our group your comment there and anything else you took away from our group? Putting you on the spot. If not, I'll do it. Awesome.
Can you hear me?
Yep.
Okay. Yeah, I think it was Holly that said she will sometimes call the patient that the medical student is going to see and ask them to come in like 15 or 30 minutes early. And then that way that they can be seeing that patient and have extra time, especially if they're giving them one that's like a more complicated patient, which actually I thought was brilliant, because sometimes you yourself could use that extra time, so the student can maybe get to the bottom of things that you don't, that you haven't had time to get to.
What I also think about in terms of that suggestion, I didn't mention this in the group, but for those of you who were here yesterday, we had a presentation on telehealth, and that works especially well for telehealth. If they're just, sitting at home, I'll often have my student call that patient like an hour before their appointment. And if they reach them, they can go ahead and start that whenever, and they don't have to fit in their exact slot because they're not showing up. So I think that works especially well in that setting. Fantastic. Oh, wait, there's one more comment in the chat. All right. I think that's it. Fish, I'll turn it back over to you.
Awesome. Thank you. These are great suggestions, and we'll work on compiling all these as well so we can share with everyone. I think the theme of helping your student learn how much time they can spend with a patient is so important. So setting those expectations. So to Eric's point of making sure we give them a framework of, you've got 4 minutes to present. And I think it's also okay to interrupt and redirect your student if things are like going, you're sitting there and you have 3 patients waiting and they're giving you a 15-minute presentation. It's okay to say, would it be okay if I stop you there and then let's focus on this particular piece of your presentation and then move on. Is totally okay. It can maybe feel uncomfortable, but as you develop that relationship with your student, you should be able to do that. All right, so we're going to move to the second. We're going to combine the second and third question. Are we out of time, Jen? We're out of time. We have 30 more minutes. Great news. And so I was like, this is going to be tough. So we're going to take 10 minutes for these next 2 questions. And if you want to build on anything else that was discussed in the earlier question, please feel free. So how do you utilize the patient care team for teaching opportunities? So thinking about who else in your clinical environment could provide valuable teaching, and you may have touched on this. And then what do you do when things sort of are too busy or everything hits the fan? So we're going to take 10 minutes here to talk about these 2 questions. Great discussion about what to do on a bad day or other teaching opportunities. So I'd love if a few groups would like to share. We've got about 10 more minutes here. Yeah, you can.
Thanks. So for the question of who else can help besides the direct preceptor, especially in outpatient clinic centers, maybe dietitians, social workers, or behavioral health specialists. Also, residents could help. We talked a couple of times about multidisciplinary clinics where students can learn from all of the different types of providers who are seeing that one patient. Also, for example, if we have a ENT specialist in our group, and so if having the student go see the allergist with the patient before coming to the ENT clinic, that also provides good continuity and another way of learning. APPs often are doing some procedures like PAPs over and over again, and so maybe having the students spend some time with APPs, or if there's too many other things going on, maybe having the students spend an hour with the clerks or the nurse manager to see how their roles play into the clinic would be useful. And for inpatient preceptors, having the student follow their patient to any radiology tests or procedures that they're having done can also be a way of using other folks to help teach students. The grand rounds piece, we thought we could use that potentially also if we're having a tough day, if we're able to tune in our students to a grand rounds lecture that's happening or other conference that's happening. That can be another way of having the student do some learning while maybe you're catching up on things. Other bad day topics, if sometimes even especially for inpatient, even if your goal is to have them see like 1 or 2 or 3 patients and pick them up for the whole day, maybe it's a day where there's a difficult conversation that's about to happen with like a family meeting, and maybe taking them with you to that family meeting so they can learn about how to manage difficult conversations. If you're potentially really behind in clinic, and maybe that it's okay to let them leave, an hour early and while you finish up and you catch up with the next patient who's coming in, that's difficult. Other options for bad days are the I talk, you type technique, in terms of we just gotta finish and catch up with this last hour for this one patient or 2 patients, I'll talk and you type.
I like the variation on that one, Shama.
Okay, so I guess just a couple things to add. One thing we talked about was if you're really busy and your student saw a patient already, allowing them to take the time to finish the notes so that they're done by end of day. And this sort of goes along with efficiency as well. It can be very difficult to sit down and then write an email to the patient. It takes extra time. But if they have their notes done at the end of the day, and so your morning session at lunchtime, you can actually give live feedback and go through the note together and edit it. And it's just a lot more efficient. So allowing them to do that kind of pays overall in the end. We mentioned this before, allowing the student to continue on with interdisciplinary staff, whether it's pharmacist, social work, for those patients that sort of go over time and need that extra care. Also, reading and pre-reading. So if you are busy and they're going to be seeing a patient later, rather than just having the student follow you around, actually identify a topic for them to sit down and read before that patient comes in, so that they're prepared and can get a really good history. And then also following the MA around, so a lot can be learned from things they do. One example I can think of, I had a recent patient who had serum impaction, and the student just kind of followed along with the MA and saw how that's taken care of in the clinic. Minnie was also saying, students can follow around and get better with the pre-charting and taking vital signs and kind of learning how that whole structure works as well. So just using everybody in your clinic for them to get all the learning experiences they can.
That's great. I think anytime you can give your students an opportunity to be hands-on and active, if any procedures or things like that are going on, they can feel really satisfying and have that authentic patient care responsibility.
So our group pretty much said very similar things. Also continuing along, like some more comprehensive and follow-up care, like why don't you, see if you can follow up on that patient we saw last week, or in the case of family medicine that delivers babies. Okay, now what's happening with the baby? The baby had a bronchiolitis admission. Let's go find out more about that. And sort of some, family care for the whole group. Following patients in my case, they get to go to the cath lab or neuro IR suite, whatever, if they're coming in with a STEMI or a stroke. Yeah, and I think almost all the same things you guys said. Did I miss anything? I'm gonna keep going.
Great. So I think a lot of what our group came up with on Zoom was very similar to what's been done. One thing that I mentioned that I have not employed, but I've heard about is if you are, this is a busy day, you're running behind, you can take a look at patients that are either coming in later that day or perhaps the next week and say, I want you to pick 2 or 3 of the patients that we either saw last week, this week, or coming up. And I want you to really do a deep dive and find 3 things that I may have overlooked, missed, or that patient still needs. Could be a specialist recommendation that I've, just glanced over and didn't follow up on. It could be, they need vaccines and they left before they were given, or whatever it is. I want you to just find those 3 things, write them down, and then at the end of the clinic or another time, I want you to send me a message if we can't talk, but just send me something so that we can be like, oh, how are we going to follow up then? Come up with a plan for how we're going to get these things taken care of.
We had a lot of the same things that were mentioned, along with, from a hospitalist perspective, having the student sort of go in after rounds and sort of talk with the patient and the family about their experience in the hospital, possibly also doing some follow-ups once the patients are discharged to see how the patient is doing, if they got their medications, all those things. I think the patient appreciates that, as well as there's some good learning. Having the patient bring in their medications and just having the student do some med rec. So going through the bottles, making sure that they have everything that they need. And then having the student teach the attending something about maybe the pathophysiology of things that we have forgotten, which then the attending could connect to sort of clinical issues in the patient cases.
Yeah, we had a lot of similar things. So making sure, stay in the room with consultants, help with procedures. If you're in a setting where you're going to have consultants in and out. One of the people in our group works in an outpatient setting, but is often able to directly connect with consultants that day, or if they're sending a patient to the ED and it's co-located, send the student along with the patient. Using your residence fellows and APPs as much as you can to help out. And if it's busy, I think the only other thing that we would add is just to make sure to explain the context with the student as to why maybe you're changing something about how you're doing it that day. And then it doesn't have to do with their performance or that they're too slow. It's just that there's a really heavy workload.
Hey, team. I don't think we have much different than the other teams, but we did talk a little bit about the boxes of important, not important, urgent, not urgent, and how your important and urgent things may not be the exact same as the important and urgent things for other people. So being able to just talk about how that impacts you and your student, about what you're going to think is most important, what's most urgent for this moment, versus what your MA or your social worker or the patient has in those boxes, can be helpful in framing out for the student why we're shifting, why we're doing what we're doing.
We're team sharing since he presented last time. So we didn't have a lot of things that were very much different besides just really emphasizing using your whole team. So making sure that you train with the MAs, the RNs, therapists, community health workers, anybody, so they can really get the student in so they see the whole clinical perspective and outpatient. Additionally, it would be a great thing during busy time periods in clinics to be able to actually have your students start rooming patients and start on a note, doing some of the duties that the MA normally would, but then carrying on with them while you're catching up or going in to see another student. A great idea was one of the colleagues here from Kaiser has an RN clinic, and being able to tap in with your student to have them go and sort of learn some of the more high-end RN skills such as spirometry, or doing multiple vaccines and following through on things like that. So once again, really emphasizing using your entire team to get a broader education for the students that are going through.
I think our group brought my own mic. I think we had a lot of the same stuff. Just one thing that wasn't mentioned that we dialogued a little bit about is just what sort of conversation should happen with that other staff in preparation, in part just to make sure, like, are they on board to have a student, you know, shadowing them or being involved? Like, it's probably worth dialoguing with them to make sure that they're sort of in agreement and aligned with the goals. And then also Anne brought up giving them specific learning goals. Like, my student's going to come with you with pharmacy, and like, here's a couple things I want them to take away just to sort of guide the learning could be helpful. And then the one last thing, Erin brought up from her students in Colorado Springs, that students had talked about how the nursing staff could be really helpful in connecting the student with the patient longitudinally and saying, oh, this person, you know, is coming back for this follow-up, or X, Y, and Z is happening. So leveraging some of that other staff to help with the longitudinal connections was something I don't think our group had thought about, but could be powerful. So.
Great. Thank you all so much for your participation. I think there's
No, can I have my Zoom group go?
Oh, sorry. Jen.
No, that's okay. It's Zoom group number 3. Mandy, do you want to speak for our group again? We had, you've already put another great comment in the chat, or do you want me just to read that off? All right. So we talked about a number of these great things. Mostly our group talked about how to engage the interprofessional team, both in inpatient and outpatient settings. And I'll just sum that up by saying, I think that ends up being one of our more powerful efficiency and teaching strategies. All sorts of great ideas around that. And then one comment that really stood out to us was allowing the med student to do some of the discharge planning in med rec. And then just the time that students can spend with patients that we often don't have adds, again, value to patient care and allows us to sort of move forward while the students spending time with the patients.
Okay, thank you all. It feels like a theme here is that there is no task that a student could participate in the care of patients that isn't meaningful. And I think just allowing the rest of your team to teach your student and not taking all of that burden, because you are incredibly busy doing a lot of different things. So use those around you to help you, and give your student authentic roles. And I think they will really grow and take off from there. Thank you all so much. We're going to take about a 5-minute break.
Yeah. Can I just reflect on something? I think the best thing about faculty development is how much I learn. I feel like I've been precepting LIC students for so long, but I was like writing down notes so fast. This is awesome. The thing I'm going to do on Monday, Brandy, your suggestion of having students reflect on my care and tell me 3 things I missed. I love that. I'm going to do that on Monday, amongst many other things. So thank you all for sharing your wisdom. That was really fantastic.